afternoon, everyone. Thank you for your patience. We were running into a couple technical difficulties, and unfortunately, Dr. Wilbur has been delayed, so we hope that she'll be able to join us. But we have Dr. Kumal with us right now, and so we'll just go ahead and get started. So thanks for joining us as we continue our webinar series being offered as part of Dr. Mary O'Leary Wiley's presidential initiative for the Society of Counseling Psychology. We are delighted that you've joined us to learn more about disability, multicultural competence, and universal design in practice settings. I'm Dr. Lisa Ferdinand, Vice President for Professional Practice, and my pronouns are she and her. Please know that you must be present for the entire webinar to get CE credit. I'll be sending more information via email about getting CE credit after the webinar. During today's webinar, you can ask questions using the Q&A function in Zoom. Following the webinar, I'll be sending a copy of the PowerPoint slides as well as any additional resources that Dr. Wilbur and Kumal have prepared. Now I'd like to briefly introduce our presenters so we can get started. I'll also put their full bios in the chat so you have access to them. So Dr. Angela Kumal is a rehabilitation psychologist in spinal cord injuries and disorders, the director of predoctoral psychology training, and the chair of the Psychology Service Diversity Committee at the Louis Stokes Cleveland Veterans Affairs Medical Center. Dr. Rebecca Wilbur is a licensed psychologist with specialized training in neuropsychology and rehabilitation psychology, who currently works at the Rehabilitation Institute of Oregon. And again, we hope that Dr. Wilbur will be able to still join us. Welcome, Dr. Kumal. I'm going to hand it over to you and just keep an eye on the Q&A.
Yes, excellent, excellent. All right, so we've got 4 learning objectives for you today: to understand the unique challenges and biopsychal concerns that people with disabilities face, identify common misconceptions that lead to discriminatory behavior in clinical practice, describe strategies to reduce bias in clinical practice, and identify strategies to modify practices and environments that align with universal design practices to decrease ableism and increase accessibility for all people. All right, so first of all, you heard from my bio that I am not a counseling psychologist by nature. I'm a proud member of Division 17 and have been one for a few years now because I share your value of social justice. Today, we're going to be talking about social justice specific to disability, but it is an honor to be giving a social justice lecture today. I wanted to acknowledge it's the 1-year anniversary of the death of George Floyd, and I know you guys are a really social justice savvy crowd, but I wanted to encourage you to reflect on the social justice implications of that event if you haven't already. So a little bit about disability and counseling psychology. So disability, thanks to the work of Tim Elliott, has not been a focal point in counseling psychology literature. So I did a search in the Counseling Psychologist from 1976 to 2021, spanning 45 years, and there were 270 publications that came up when I searched for disability. Most of them, disability was a periphery topic. So what I'm hoping today is to inspire you to really include disability in the fantastic multicultural and diversity work that you're already doing. Another reason that we are so excited to be here with you today is because we found that university counseling centers had the highest reported rates of interns with disabilities in any training setting, okay? So supervision of students with disabilities is a topic Rebecca and I are really passionate about. So some of the reasons we think students with disabilities gravitate towards university counseling centers is because universities have an established disability office who is used to providing accommodations, and because of the social justice value of counseling psychology. And those are just our theories. All right, so to start with some background basics, so how do we define disability? So my favorite way to define disability goes to the Americans with Disabilities Act. The ADA was enacted in 1990. So the ADA protects qualified individuals with disabilities. So they define a disability as, and I take this language verbatim, a physical or mental impairment that substantially limits one or more major life activities of an individual, a record of such impairment, so that captures people with episodic disabilities or being regarded as having an impairment. So if someone has facial deformity, it doesn't really interfere with a major life activity, but someone could perceive that it might and discriminate against them. So the ADA protects people who are being regarded as having an impairment too. So what do we mean by major life activities? So when the ADA was enacted in 1990, the list was pretty limited. It consisted of seeing, hearing, walking, caring for yourself, learning, breathing, and working, okay? So that's really limited. And it wasn't until 2008, which really wasn't that long ago, that they included performing manual tasks, eating, sleeping, standing, lifting, bending, speaking, reading, concentrating, thinking, and communicating, as well as the operation of several specified major bodily functions. So it's only since 2008 that individuals with chronic health conditions could be protected, individuals with issues with cognitive functioning. And so when we talk about invisible disabilities, they're a more recent addition to the group of people with disabilities. So I love the definition the ADA gives us, but there is gray area. It's not black and white. So then one of my favorite quotes is disability in the eye of the beholder? So the perception of ability can vary greatly between people, individual with a disability and others they interact with. And this can bring up strong psychological sentiment too. All right, so a few disability stats. So 49.7 Americans live with one or more disabilities. So this includes 9.4 who have a sensory disability, hearing or vision, 21.2 have a physical disability, and 12.4 have a physical or mental condition that causes difficulty in learning, memory, or concentration. So I always find those breakdowns interesting. So this is 20% of the population, and it's on the rise because of medical advancements. People are living longer with chronic illness. 3 out of 10 current young adults in their 20s will become disabled before they turn 67. So that's 1 in 3. And then someone may also experience the disability of a loved one, because disability doesn't just occur in a vacuum. And then disability prevalence is higher among women, older adults, racial ethnic minorities, low SES, those with low education levels, and then something that's super interesting is those who identify as LGBT. All right, so after acquired disability, so a little bit on intersectionality here, after acquired disability, ethnic minorities do have a harder time. So they're more likely to have secondary complications, secondary health complications. They're less likely to be employed. They're less likely to be partnered or stay partnered after acquired disability. And they have worse outcomes when they do participate in rehabilitation programs, okay? And then I always like to share some unique experience. First of all, women with disabilities are very near and dear to my heart. So some unique aspects of being a woman with a disability, they are at increased risk for abuse and interpersonal violence related to their disability. Disability associated role changes, such as how they adjust to being a mother with a disability. And then also in terms of dating and sexuality, it can be very challenging for a woman with a disability to feel valued and find a partner or stay partnered. So some unique experiences when an individual identifies as LGBT and disability is limited access to fully accessible and inclusive LGBT resources. Something that's interesting is bullying is a significant issue for kids who are embracing this identity and also have a disability, not being fully recognized for both identities in either community. And then something that's disability and sexuality is really another issue that's near and dear to my heart. So hard to find partners and resources specific to sexuality, disability, and LGBTQ are very scarce. All right, so a little bit on different types of disability. So there's physical, which can range from visible, like a spinal cord injury or an amputation, to maybe something invisible, like multiple sclerosis or arthritis. Cognitive, traumatic brain injury, dementia, learning disability. Developmental, autism, Down syndrome, and sensory disabilities, blindness, hearing impairment. And then also don't forget mental and emotional disabilities. And these can range, schizophrenia, MDD, bipolar disorder, generalized anxiety disorder, depending on how they impair with daily functioning or major life impairments, if we're going to go by the ADA. Okay, so disabilities are either acquired, meaning they occur after birth, or they're congenital. So most disabilities are acquired, which means they are the result of an injury or illness or diagnosis. They could be traumatic and sudden, or they could have a gradual onset. Congenital disabilities are present before or at birth. So there's an assumption that someone with a congenital disability would adapt better or adjust better to their disability because they don't know anything else. But this is unsupported by research. They may or may not have other disabled family members. So that's something that's interesting about disability is the person with the disability may be the only one that they know having their disability. All right, so something that's unique about disability is there's significant intergroup diversity. So when you think about disability, the stereotypical views emphasize wheelchair users and other classical groups, such as being blind and deaf. But the thing to remember is that not all people with disabilities are equally advantaged. Some members of this group are quite privileged. Social comparison as a result of viewing disability stereotypical can be problematic. So for those of you who don't know me, I'm a wheelchair user, and I've had people say to me, they might have a non-apparent physical disability, and they might say, well, I don't want to take an identity that's really reserved for people like you. So because they view themselves as so different from me being a wheelchair user, they have a hard time understanding that we're really all part of the same group. So other interesting fun facts is children with physical impairments fare better educationally than those with intellectual or sensory impairments, and those with mental health disabilities or intellectual impairments are the most discriminated against in employment settings. Okay, so just think about all the different issues within this same group. All right, so one of my favorite things to talk about is disability language. So within the community, most people are familiar with the concept of person-first language, which talks about people with disabilities. Okay, so this came about after the Americans with Disabilities Act, where they thought that you should view someone as a person first and view the disability as one part of that person, okay? So this positively counteracted with widespread negative use of objectifying terms like the cerebral palsied. And then this also became widely popular in organizations like APA Style used to really push person-first language. Now, more recently, diversity model proponents criticize the use of people-first terminology. So they say that if you say the disability is second to the person, that there's something wrong with it. So why is it important to separate the person from the disability and de-emphasize the disability? And does it overcorrect to the point of further stigmatizing disability as part of the human identity? So these are the two opposing pool of thoughts, okay? So whether you're going to use person-first language or identity-first language can be a tough decision. So decisions about language are ultimately personal ones, and they based on different factors involving the people with disabilities that you are discussing or interacting with. So preference comes down to disability acquisition and permanency. Where is someone in the realm of disability identity development? And then what have their previous experiences been with negative terminology? So in the most recent APA style guide, they now say use person first and identity first interchangeably, or ask the group or the individuals that you're working with what their preference is. And just an example of identity first language would be like referring to me as someone as referring to me as a quadriplegic. Okay. All right. So now we're going to talk about invisible disability and the visibility of disability. So some disabilities are apparent or obvious. Others are invisible or non-apparent. Okay. So maybe our talk has started to make you more aware of the diversity within disability and some of the cultural minority group challenges. Another important thing to be aware of about disability is that not all disabilities are visible. In fact, it's more likely that a disability is invisible or just not apparent just by looking at someone. So 40% of the disability population in the US consists of invisible or non-apparent. And people with invisible disability have great impotence to keep their condition concealed because of fear of stigma, fear of discrimination, fear of negative consequences. Okay. And we also say that the 40% is probably an underestimate because there are a lot of misconceptions about what it is to be disabled, including the range and variability of disability. Oh, I think Dr. Wilbur has joined us. Welcome.
Hello, I apologize for the delay.
Welcome. Are you ready to jump in? Slides.
I am. Wow, it's perfect timing, doesn't it?
Yes.
I apologize for the delay, everybody. Okay. Are you able to see me? I'm not able to see myself.
Yes.
Okay.
Yes,
we are, Rebecca.
Okay, very good. I apologize. I'm not able to see myself at the moment in the video, but that's okay. So we're going to talk a little bit about invisible disability. It says here in your slides that about 40% of the US population that is part of the disability population has invisible disability. That's probably an underestimate. There are really a lot of misconceptions about what it is to be disabled, including the range and variability of disability. There's the belief that seeing is believing. If you can't see it, then it must not exist. And therefore, many people with recognized and very well documented disabilities and conditions who, based on their condition, would meet criteria for example, reasonable accommodations from their employer or from their work, may be denied accommodations because their employer or professor doesn't see the disability and may not understand that disability is not always visible. In addition, in order to get reasonable accommodations, a person with invisible disability has to then disclose their disability in order to get reasonable accommodations. But once a person does that, then they open themselves up to a lot of discrimination bias. Well, you look fine, you look good, which kind of leaves this implication that the person is lying or exaggerating in order to receive a a break or some kind of accommodation that they consider to be taking a shortcut in some way, or to avoid their responsibilities. So because of that, many people with invisible disability conceal their disability and never disclose in order to avoid that constant disparaging and invalidating comments and attitudes, which is why people with invisibility have great impetus to keep their condition concealed. Research has found that those with invisible disability also tend to experience more emotional distress than those with other visible manifestations. And we believe it's due to the differences in the perceptions and biases that are held against people with invisible disability. So next slide, please. So because of the expectation that seeing is believing, in many cases, people with invisible disability may not recognize themselves that they have the disability, and they may have a type of they may have disability biases themselves and may not identify in that way. They may themselves hold negative disability bias and may even become offended if they're told that they had a type of a disability, because they themselves may have a conception that disability must be visible in order to be recognized. For those that are aware and do identify and recognize that invisible disability is a type of disability on the spectrum, and it doesn't necessarily make them less than, it's important to recognize that their symptoms may not be static. So for example, with chronic pain conditions, pain changes depending on the activity, depending on if there's a flare. Same thing for something like a chronic fatigue syndrome. Fatigue may also change. It may change during different times of the day. It may also depend on what challenges the person is experiencing, or if there are new medications or treatments that the person is receiving that may make their condition wax and wane in different ways. So disability isn't necessarily static, and that's especially true with invisible disabilities. There's also the difficulty related to ambiguous diagnoses. There's still different diagnoses that are notoriously undermined in some way, like autoimmune disorders are often very difficult to diagnose. Seeing certain specialists for a particular disorder may be very difficult. And it may be that the person is required to be seen by a specialist and have documentation in order to receive necessary accommodations for their job or for school. And in the meantime, when they're not receiving those particular reasonable accommodations for a condition that they have, the challenges related to the disability become in some ways more disabled and more dysfunctional because they don't have the reasonable accommodations they should be afforded. So these are some, again, unique challenges to people with invisible disability. We'll go ahead and go to the next slide. So this kind of compares and contrasts some differences between visible and invisible. So when the disability is visible, others are more readily accepting as that's something to accommodate. But with invisible disability, they may not be seen as legitimate, or they may have to prove that they have disability in some way. For visible disability, disclosure is automatic. You can see it. You can see that that person uses an assistive device of some kind. But for invisible disability, they have to disclose. And there's often a lot of challenge internally for the person about whether or not it's safe to disclose. And they have to weigh the benefits of, well, I could get these accommodations which could help me to be able to perform at my best and be able to do everything I'd like to do, but I'm going to get questioned as to whether or not I'm lying. And so that's something that the person has to wrestle with. Also, the folks with visible disability, they're often labeled as disabled, whereas and there may be certain automatic biases that come along with that, assumptions of what the person can and can't do. Whereas with invisible disability, because they have to disclose, they may be able to pass as non-disabled. And so there may be certain feelings of safety that come along with that, because they're not automatically receiving a lot of the bias that may occur with visible disability. So there's different challenges depending on the type of disability, whether it's visible or invisible. Okay, next slide. So this one, are you really disabled? This is a particular apparently game that's being played, and it's the vehicle dismount. This person has to use a wheelchair to get out of the car, therefore they must be really disabled because they're using a wheelchair. And then the next slide about invisible disability. How do we know if they're actually dead or just pretending? And someone yells out, I have a chronic illness, kale, yoga, juice cleanse, because automatically everyone feels the need to tell the person with the chronic illness or the invisible disability that how they need to fix themselves. It kind of insinuates that the person with invisible disability doesn't know how to care for themselves, or if they just did things differently, then they wouldn't have a disability at all, or it would simply fix their condition. And it implies that the person living with the condition, you know, just can't figure out that magic bullet to be able to manage it properly.
All right. So I am going to take back over to talk about one of my favorite topics, which is the conceptual models of disability. Okay. So these models are used to determine how different people view disability. Okay. So the first one is the moral model. So this is my least favorite. It's the oldest model of disability. It's less prevalent today, but it's still very present. So it associates disability with sin and shame. It may or may not be based in religion doctrine. So someone who views disability through this model might say, gosh, what did I do to God? Or God must be punishing me. Disability is a burden, and there's a lot of a shame associated with it. And because of disability, they don't have a meaningful role in society. So there's general social ostracism, self-hatred. So some charity organizations view disability through this model when they're trying to use someone with a disability to gain donations is a great example. So because of the disability, they can't have a meaningful role. All right, so the next model is the medical model. So it came about with modern medicine in the early 19th century, and this model perceives disability as the failure of a bodily system. These individuals are very focused on a cure and putting a person with a disability in the sick role. So they're excused from the normal obligations of society because they're sick. They're expected to submit to the authority of medical professionals. It heavily influenced the public policy system. So Social Security disability means you are unable to work. Okay. And then the interesting thing about this model is, although medical interventions can be helpful, most disabilities can't be cured. So all right, so the next model is my personal favorite. So this is the social model. So this came about with the Americans with Disabilities Act, which conceptualized that disability is a neutral characteristic or attribute, and the problem is the environment. So it's a social construction. Okay, and the focus is on external barriers like physical obstacles to building access. It also really focuses on attitudinal issues. Do people have attitudes about what they perceive someone with a disability can or can't do? This model really embraces person-first language. So for me, this model really came to life for me. I'm an individual with a disability who's pretty independent in an accessible environment. You take me out of my accessible environment. In 2006, I traveled to ancient Greece, and there were a lot of obstacles. And because the environment wasn't as accessible, my disability, I needed more help. I wasn't as independent, and my disability was more impairing. All right, the last model is called the minority model. So this says that disability is a natural difference on the spectrum of diversity. It's a normal aspect of life and not a deviance. So this model really embraces the disability culture, socio-political experience, and identity. And this is where identity first language comes in. And these are the real disability activists who really embrace disability pride. All right, so who holds these models? Well, so the patient may hold one model, the family may hold another model, and you as the psychologist may hold another model, all of how you're conceptualizing disability. So the models really affect how the problem is conceived, the focus of treatment, the goals, and adjustment. All right, so one of my favorite quotes is that the main thing disabled people need to do is claim their disability to feel okay about it. Even if you don't like the way society treats you as a disabled person, it's part of your experience. It's part of how you come to be who you are. So this really speaks to the process of disability identity development. And then the next quote is also one of my all-time favorites. Judy Heumann is someone that I really look up to, and as a disability activist, and she says, "It's not a tragedy to me that I'm living in a wheelchair." And this really speaks to all the resilience that's in the disability population. All right, back to you, Rebecca.
Okay, so we've started to introduce you folks about some of the differences or attitudes or bias towards people with different disabilities, but we started to compare and contrast some of the differences between visible and invisible disability. Well, a few more things we'd like to share would include awareness that really the literature shows that the most difficult challenges for persons with disability involve the social stigma and discrimination, not the physical or mental or emotional challenges that are associated with the person's condition. So the cumulative effect of these negative attitudes, referred to as microaggressions by Sue, leads to the oppression of persons with disabilities. And psychologists themselves, we are not immune to developing different types of biases and discriminatory practice or prejudice towards people with disability, which is why we give this talk. It's really to raise awareness, because the number one sure way to perpetuate bias for us as psychologists is lack of awareness. Let's talk about the different types of attitudes. So they really are on a continuum. From catastrophizing, looking at people who are with disability as a burden, they're second class, they're inferior in some way, or unattractive in some way. Pity, feeling sorry or patronizing the person with disability as having disability means that they're suffering. Fear, which often people may focus on the fear of having that particular disability, partially because it's bringing up questions or concerns about their own mortality, or about the fact that all of us are frankly vulnerable to be able to develop a disability at any time. And all of us in some form are likely temporarily able-bodied and will develop disabilities over time with age. And many people, the fear comes up because they may not want to think about that or to address it. Hero worship, seeing someone as being very brave or special or unique for being able to do so much, for overcoming disability, or coming up to someone who's in the grocery store and saying, "Oh, you're such an inspiration." And they're like, "I'm getting apples. How is that an inspiration?" Also looking at things like saying that they're, courageous for just existing or doing something that's very simple. The spread effect is also something that we try to make folks aware of, because there seems to be this idea that impairment is perceived globally. If a person's in a wheelchair, they must also be mentally disabled, for example, or different stereotypes, both positive and negative, can really diminish the person's individuality and really dehumanize them. In fact, Angela has a really good example.
Yeah, so this is a great picture of the spread effect, in which Someone operating the elevator is using a megaphone to the person in the wheelchair. So just a great example from my own life, when I went to APA in 2009 in Toronto, and I was flying out, I was traveling with my sister, and I was escorted by the TSA agent around the gate, the metal detector to get my pat down. And when we got back there, we waited. I'd never been to Canada before. I didn't know the protocol. The TSA agent waited for my sister to go through the metal detector and get our bags and come over. And she explained the pat down procedure to my sister and asked her if I had any sensitive areas that she should avoid in a pat down, because she didn't think that I would be able to understand and answer her questions. So I'm really lucky. My friends and family are very comfortable with disability. And my sister said blatantly, like, she can't walk, but she talks just fine. And the poor TSA agent was very embarrassed, but I think we tried to make it a teachable moment. All right, being mindful of time, we are going to move on.
So ableism. So what people don't realize is that if you're not looking into the deeper subtext of the moment, and while a person may come up to someone who's in a wheelchair in the grocery store, who's getting apples, and may say, "Oh, you're such an inspiration," what they're not looking at is that there's layers. It may seem like it's not hate driven, but what they're not recognizing is that there's an underlying message there that says that the person who's in the wheelchair is inferior in some way. What right do I have to be miserable? At least I'm not in a wheelchair like you. You poor person in a wheelchair who is clearly disabled. There's also particular difficulty accepting the value in a disability identity, given the medicalization of disability. And as we've seen above in the models, there's really nothing inherently wrong or inferior about having a disability of any kind, whether it's visible or invisible. But many people struggle to accept having value in having their disability, given the medicalization of disability. And, the prevalent myths of it being a tragedy, people need cures, or disabled people want special privileges, and that's what reasonable accommodations are. That disability access harms American businesses financially, which is a huge misperception, because most reasonable accommodations cost nothing. Mostly they're having some kind of a flexible schedule, or having flexible work, or things. The most expensive reasonable accommodation that I can think of is the door paddle to be able to make a door have an electronic opener. That costs about $500, and that's the most expensive one I can think of. So there's this misperception that reasonable accommodations cost this huge amount of money because of all this restructuring, but that it simply isn't true. Most reasonable accommodations are actually things that just allow for a more flexible work environment that actually ends up creating more job satisfaction, not just for the person with disability, but often for many of the other people in that particular business as well. It's really just about having, it's a similar kind of attitude to being colorblind. You're not wanting to acknowledge that there's a reality beyond or different than one's own experiences. So for all of the reasons listed above, the most common misperception of psychologists that we run into is that assuming that the person is in your office for therapy because they have a disability, or the simple fact that they're in a wheelchair, or because they have chronic pain. But most of the time it's due to any other psychological concern that anyone in the population could develop. Or they're experiencing emotional reaction to the biases from having just experienced discrimination related to the disability and being part of a minority group, not the disability itself. And so this kind of relates to this insider-outsider distinction. The insider, the person with disability, may be experiencing depression or anxiety for any whole host of reasons for anyone in the human condition. But the outsider, the psychologist, may make the assumption that, oh, it's because you're in a wheelchair, it's because you have chronic pain. that may not be the issue. It's about kind of taking a broader view and not having this misconception that disability is the reason or the problem for everything. All right, next slide, please. So some practical tips for examining and navigating personal biases is some things to ask ourselves. Do you see disability? Is it visible? Do you see invisible disability as part of your daily work? Is that something that's in your consciousness? If not, I definitely encourage you to start raising your awareness around that and start looking around, even starting with the physical environment, and then broaden your idea of what disability could include, including invisible disability, which may not be readily apparent. Do you routinely ask about this, about different diverse identities? Or if so, why or why not? So what types of feelings does disability bring up for you? How might that transfer to a patient? So kind of being aware of our own projections that may be happening. Reflect on those. You really set the tone when you ask about disability. And sometimes, especially in the beginning, if this is something that you're new to thinking about, it's uncomfortable, that's okay. That's still part of the growth edge, and that's okay to experience. So is segregation okay? So in addition to many of the assumptions that we may hold, we also need to look at the assumptions that are inherent in the environment around us. So take a look at some of these pictures. Have you ever noticed that the disability entrance is always in the back? Or that the disability access bathroom is always the one that's furthest back? It's a type of segregation, and it's really something to be aware of. Which leads me into talking about universal design. So universal design is an approach to creating a universally accessible environment by creating products, environments, technology that's been developed to be usable by all people without the need for adaptation or accommodation. I love the picture that I included on this slide that talks about building a wheelchair access ramp and building the stairs around it. So it really is taking the essence that a barrier-free design is essential to living a happy life, and kind of keeping that in the framework of even how you're developing everything around us. So you may see these kind of shifts towards universal design, especially talked about in educational literature. A lot of articles came out about universal design and adapting education to be more inclusive during the COVID era, which was really a shift towards universal design and suggests that many people learn in different ways. And so we need to approach learning and education and teaching from many different angles to be able to include a variety of different learners. And that's also a very universal design approach, and it's the universal instructional design. So spaces can be used equitably by all people, simply and intuitively with low physical effort. How can we do that also with our education system? Next slide. So the 7 principles of universal design: making it equitable so that anyone, regardless of their ability, is able to use it. It should be flexible in its use, simple and intuitive to be able to use, with perceptible information, low tolerance for effort, and high tolerance for error, and having the size and the space to be able to use these things regardless of how the person needs to approach it. So a little bit of understanding the universal design is also understanding some of the journey of social justice for disability. So on the far left in this picture, you're going to see the very first symbol of access, the International Symbol of Access, which was established in 1968. Something you may notice looking at it is that the person in the wheelchair doesn't even have a head, which tells you something about the biases towards people with disabilities at that time. They weren't even personhood enough to warrant having a head on the body of a person in the wheelchair. That did change slowly, but within a year, the person had a head, but it slowly developed over time we can include the far right picture as being much more inclusive. The focus is more on the person, not the chair. And so it's more about the attitudinal changes, as well as we're looking at the progression of more accessibility in our environment. So moving from impairment-based environment to barrier-specific. Again, this really is really thinking about everything from the moment of conception, trying to think about who are going to be the users in the environment. And that's going to include physical, sensory, cognitive, communicative, all those different ways in which we as humans show up in an environment. And so trying to be as inclusive and diverse as possible. So we're going to go on to the next slide, especially for the interest of time. So this goes through different options for consideration when you're thinking about the different aspects of universal design within a therapeutic environment. So there may be physical things. How accessible is the furniture or the maneuverability? And that may include ADA access, but it may be beyond just ADA access. For example, could a person in a wheelchair come up and speak to the person at the front desk without just having a wall in front of them, because the reception desk is really for people who are standing. So just being aware of some of those physical changes. Sensory, you may be able to have an environment that's adjustable, also paying attention to like the scent or the sound. Communication, it's often checking in with the person's preferred method of communication, which may be different for a variety of different reasons. For example, some folks may have very easy access to cell phones, other folks may not. For some people, filling out the forms on a computer is actually harder than filling them out in paper. Or for others, it may be reversed. It depends on the person's own particular challenges or strengths. Let's go ahead and go on to the next slide. So we're kind of comparing and contrasting the accommodation approach versus the universal design approach here. On the accommodation side, access is a problem for the individual. It should be addressed by that person or the disability service program. In the universal design approach, access really stems from poorly designed environments, which can be addressed from a design perspective, again, making it more universal. Access, on the accommodation side is achieved through accommodations and kind of retrofitting existing structures, whereas the universal design approach, the system or environment is designed to be, as to the greatest extent possible, usable by everybody. It's trying to be as inclusive as possible. For the interest of time, let's go ahead and move on to the next slide. So you can kind of see here equality versus equity. So in the first image, it's assumed that everyone benefits from the same supports and they're treated equally. But the result is that some people who are trying to enjoy the baseball game still can't access it. So in that case, while they may equally receive supports, the end result is not everybody can enjoy the same things that others do. In the second image, we're looking at accommodation. So different individuals are given different supports to make it more possible for them to have equal access. But in the third image, we see that the fence has been changed completely. So the systemic barrier has been removed. So it changes the need for accommodations to begin with because it was made more accessible from the start.
Can we fly through these, Rebecca? Because they're going to get
our
slides.
You guys are going to get these slides, so I won't go through these, but these are some resources to consider if you want to make adaptations to your environment or to your therapeutic approach, wherever your office may be. So we'll go ahead and flip through these and get ways to make practice more inclusive.
All right, so I've got the last few slides to wrap us up. So how can you make your practice more inclusive? So think about the access from the universal design perspective in both your office and your clinical layout. So a couple of things I wanted to point out is know where the bathroom is and what features are there. Because even if someone can describe to me what's there, I can know if it would work for me. Okay, and then the other big point about inclusive practice is if your office is by public transportation, you can be so much more inclusive for people with disabilities who may depend on accessible transportation to come to see you. Okay, so envision your clientele with the assumption that some of them will be disabled, even if it's not apparent. And then you can make known your commitment to an inclusive atmosphere. So you can include reasonable accommodations willingness statement in any written material. And then, by demonstrating knowledge of accessibility, those are signs, those are ways to demonstrate that you have an awareness and an appreciation for disability issues. All right, so enhancing cultural competence. So become familiar with the experience of living with disability to increase empathy and understanding. So I hope that all the examples we shared today will help you appreciate the hassles and everyday experience, that isolation can be real for people with disabilities, that intrusive stares and questions are very usual. And then especially for the non-apparent or invisible disabilities, that doubt and questioning is a big part of their experience. So something we didn't talk a lot about today, but is really important, is individuals with disabilities face the same developmental tasks and milestones as anyone does. Friendships, education, developing an identity, dating and sexuality, getting a job, having children, and then dealing with aging, okay? So the ability to achieve these goals often depends less on the nature of the disability than on personal, familial, systemic interactions with schools, employers, healthcare providers, and communities. Further your own efforts towards cultural competence. So I hope that everyone's going to go back to their institutions and think about how they can integrate disability-related case material and topics into their professional discussions, study groups, and seminars. Identify contacts in your community and support professionals that you can reach out to, and become familiar with disability resources in the community, like your local Center for Independent Living, adaptive sports, and advocacy groups are great. All right, so if you want to learn more, last slide, focus on the intersections of multiple diverse identities to include disability. Read works by disabled authors about the lived experience of disability. Judy Heuman's book was a 5-star read for me. Learn more about the disability rights movement. Watch a movie or documentary about disability. Crip Camp on Netflix is highly recommended. Engage in use of self to examine your own disability biases. And something else we didn't talk about today is simulation exercises. So where you simulate having a disability, those are not something we recommend because it can be difficult to process how to cope and manage with disability barriers in the environment. So, all right, I think we are just about out of time, and I see we have a long list of questions that I have yet to bring up.
That's okay. Maybe we can do there's one that might be a little bit shorter. And then what I put in the chat, Angela and Rebecca, is that I'll send you the questions and that possibly you'll be able to address them in the resources that you share, or we'll share your contact information so that people can also send you questions individually. So just a quick one, can you speak hopefully quickly to are substance use disorders considered a disability? That was one of the earlier questions.
Oh, that is, that's really, really controversial. So they can be considered, so like if they needed an ADA accommodation, as long as they're not using to attend rehab, like they might be able to get an accommodation from their employer to attend treatment, that could qualify for protection under the ADA. That's a really, really good question though. And it is very, very tricky as to when they're going to qualify.
Great. Well, I will be sure that I get any other questions that we get in to you both so that you can consider and hopefully maybe share some additional resources. I wanted to thank everyone who was able to attend the webinar. Again, my apologies that we had some technical difficulties and got started a little bit late, but really glad that all of you could join us. Again, I will send an email within the next 48 hours or so that will have a copy of the slides as well as any resources that our presenters are able to share with us. And just thanks again for sharing the space with us. Thank you so much to the both of you for your time and your expertise and your passion.
Yes. Okay.